I am here to introduce Dr. Ritesh Shah. His area of interest is mechanical ventilation, hemodynamic monitoring, and error prevention in CPR. He is a authorized chapter of book Critical Care Updates 2019 Critical Care Quiz, textbook of critical care medicines. In short, he is very interested in the critical care management, and he is a faculty and course director for American Heart Association for basic life supports, BLS and ACLS, and IRC for BLS and CCLS. Uh, there are many more figures in his cap, but I would, without going into detail, I will request Dr. Ritesh Bhai to continue his talk.
No, thank you, sir. Thank you for the introduction. I thank the organizers for having me here. A very good morning. So today's topic is hypovolemia and dehydration. Now all of us probably are hypovolemic at this juncture, but probably may not be dehydrated. So let me go through the journey. So I'm not going to details of intravascular, extracellular, but we know that it's an intracellular component and extracellular. Extracellular is divided into interstitium and intravascular, and primary we can play around only in intravascular compartment, and it is a very small segment. So I'm going to go through not the things but the myths and facts, what we believe, and sometimes it is not so. So myths and facts, hypovolemia and dehydration are the same, yes or no? See, hypovolemia describes the loss of sodium from the extracellular space, that is intravascular interstitial, decreased volume of fluid in the vascular system with or without total body fluid depletion, wherever dehydration means total body water loss. So dehydration means from all compartment the fluid is lost, but hypovolemia is only and only extracellular, that is intravascular. So any patient who is hypovolemic may not be dehydrated. The question, hypovolemia and dehydration are the same? Absolutely not. Hypovolemia and dehydration are not a single thing. Myths and facts, hypotension and shock are same, yes or no? Absolutely no. We know that hypotension is a number. Like the previous speaker has already said that if hypertension is there, don't decrease to 130, 120. It may be hypotension or shock for that particular patient at that particular time. So hypotension is a number of the blood pressure that we measure, whereas shock means a state of low tissue perfusion when the total body water is depleted or from XYZ pathology. If the perfusion is not maintained, then and then we can call it shock. So if any patient comes to with 80 systolic, I will not label that patient is in shock. I will label first as hypotensive, may or may not be having shock. Then we need to see the tissue perfusion markers. And whether blood pressure is equal to cardiac output, see what tissue perfusion is dependent on cardiac output, right? So blood pressure actually is not equal to cardiac output. 80 systolic blood pressure, the perfusion is very well, patient is walking, talking, all of us we are seeing 90 systolic, multiple patients are there, and 150 systolic, but still patient may be dizzy, patient may be having some signs of hypoperfusion including low urine output. So the number is just for the blood pressure, may or may not related to the tissue perfusion. So it's a myth that hypotension and shock are same. Many times you just 80 systolic, you give 200 cc of fluid, 400 cc of fluid, and blood pressure is up and above. That doesn't mean that patient was in shock. In third space, I know that it's a entirely different topic. Third space, that all of us we see that peripheral tissue edema and this and that. Any edema does not essentially mean that patient is volume overloaded. Patient may be edematous, but in 6 with 60 systolic, all of us we are seeing. So intravascular compartment may be completely empty. Whatever we are giving is going out. Maybe because of severe hypoproteinemia, because of leaky capillaries secondary to sepsis, and so forth. So third space accumulation of fluid does not mean that patient may not require fluid. So it's a big myth. So करने का क्या? Whether it is low BP, poor perfusion, करने का क्या है? Fluids, agreed? Fluids, and no, we have to give vasopressors also. So it's not only fluids, but vasopressors as well. So what is fluid? I would label the this thing as most important and most commonly used drug in the hospital. It is a drug, and we have to consider fluid as a drug. And any drug that we titrate, we see indication, contraindication, complication, fluid we need to consider right from time zero. And I would rather further label that most commonly misused and overused drug. What we see, અને 2 pint આપી દેજો અને 4 pint આપી દેજો. Fortunately, with God's grace, our tissues are so powerful to handle this additional burden, but it may go other way around also, right? So the things do not warrant any close observation, then it's fine. But things when the organ functions are borderline, patient's heart condition is borderline, this condition, so a lot of patients on edge, this matters. So we should not prescribe fluid just as 2 pints, it has to be in ml. So I won't go into detail of intravascular volume status and fluid responsiveness. It is like all of us, pre-lunch session. What is our intravascular volume status? Whether we require fluid, the intravascular volume status may be low, but we are up and above, so we don't require fluids. So same way as patients, that even if intravascular volume status is low, you need to find out the reason rather than just giving fluids. Why we need to know? Any less amount of fluid, perfusion is a problem and starting of multi-organ failure. Any higher amount of fluid, then pulmonary edema and so forth. So if I have to choose, I would say that I would like my patients hypoperfused or hyperperfused, a bit low on the fluid or high on the fluid to start with. Yes, remember, to start with I am talking about 0.0. I would like to give a little bit of more fluid cautiously under monitoring, because hypoperfusion initiates multi-organ failure, and even if you give more amount of fluid, you may land up in pulmonary edema, which is relatively easy to tackle. People are more afraid of pulmonary edema rather than organ deperfusion. So organ deperfusion leads to multi-organ failure, and hypervolemia actually leads to single organ failure, that is pulmonary edema, which is relatively easy to get rid of, right? So that doesn't mean that we have to just load and load the fluid. So these are the parameters. It's a core critical care subject. See, when we think in short that this patient requires fluid, it is like, toss of a coin. We are only 50% of the right in critically ill patients. So another myth, fluid loading, fluid challenge and fluid resuscitation are same and interchangeable terminologies. Everything is different actually. Just I'll simplify it. Fluid resuscitation, there is a large amount in most cases. It's a rapid, that is in short interval. The targets are defined, that we want 65 mean, that's my target. But type of fluid is not defined. Whatever you want to give, but more crystalloids and crystalloids, that I'll come little later. Fluid challenge means X amount of fluid in X minutes. It may be mini fluid challenge, it may be fluid challenge, it may be 500 ml over 30 minutes, it may be 200 ml over 10 minutes. The targets are defined, but type of fluid is not standardized. And fluid loading, so this fluid loading we have to debarred from the table. So this already I had taken up. So all are not same, and there are key components of fluid challenge, that is type of fluid, rate of fluid administration. We have to have certain objectives in particular patient at that particular time, and we have to have our limits, that when I want to stop. Majority of the time there are two criteria that we start fluid. One is hypotension, one is decreased urine output. These two are the triggers for fluid, for us to start fluid. But unfortunately we do not have definition then when to stop fluid, except that okay, 65 target is there, continue 65, but then the variation is less once that number is achieved. So there are a lot of papers, I am not going into detail, that CVP and this and that everything. Yes, CVP is out of favor because there are a lot of fallacies in CVP. We don't use CVP nowadays except in a very small subset of patients. I had not used CVP as a marker of fluid responsiveness as well as intravascular volume status since last 12 years now. So it is out of the woods. Yes, still we need to put central line for other reasons. And we know that there are super market of IV fluids which are available in here right now, but we need to be very, very cautious in choosing the fluid. So colloids are more effective in initial fluid resuscitation. Yes, no, can't say, maybe, yes. So colloids are, I'm not going to detail of colloids, but please believe me, any patient who comes with shock, colloids are very, very dangerous. It can cause two things. Number one, there are very high chances of AKI, that is kidney damage, and second is coagulopathy. So any patient who comes with shock, please do not start patients with colloids. It is now very well proven that we have to start with crystalloids and not colloids at any cost. Another thing, normal saline is most physiological fluid for resuscitation as it is isotonic. Yes, no, maybe, can't say. All of us, we start as a knee jerk. NS. What is this? It is 0.9% sodium chloride. You can say this. 7.4 is the plasma pH, 5.7 is the normal saline pH. See, the osmolality of plasma is 290. I am talking about upper limit. See, this is hypertonic. So NS actually is hypertonic because of the chloride. See the chloride level. Chloride level is 154. This is slightly higher sodium, but chloride level is 154. This can actually, already patient is having metabolic acidosis, and addition of additional burden of chloride can cause hyperchloremic metabolic acidosis. So if you give more saline, actually you see that why this acidosis is worsening. It is because of too much loading of normal saline in already existing metabolic acidotic patients. So we have to be extremely careful if we want to give higher amount of fluid in liters, maybe 2 liters, 3 liters, 4 liters, already in hypotensive patients, probably sepsis, probably lactic acidosis. Be very careful, because this patient, the blood pressure will be up, but metabolic acidosis will worsen. So I call it normal saline as abnormal saline. It is not called normal saline. Any fluid can be used for initial resuscitation, crystalloid, colloid, 5% dextrose, NSRL, anything. NS, we know that by knee jerk reaction we do it, but ultimately we have to literally see which are the plasma contents, and depending on that which are the fluid content. Depending on that we can go ahead. So the best fluid for resuscitation is ringal lactate. Why? It is as near as possible to our plasma electrolytes as well as pH as well as osmolality. So even large amount of ringal lactate if we give, patient is not going to worsen as far as metabolic acidosis is concerned. So if initial fluid of resuscitation, when large amount of fluid needs to be given, ringal lactate is a choice. Minus 2 conditions. You see, this is slightly hypotonic. It is almost matching our plasma osmolality. But in traumatic brain injury, we cannot give very high amount of hypotonic fluids, even if this is simple, very, very marginal hypotonic fluid. Otherwise, the brain tissue swelling increases in traumatic brain injury. And second is extreme liver failure, because it contains lactate. Now, lactate is usually converted into bicarbonate in good liver, but extreme liver failure, where fulminant hepatic failure, I would slightly worry to give large amount of ringal lactate as an initial fluid resuscitation. In there, I would match ringal lactate and normal saline together, maybe alternate pint, so as to balance the to prevent hyperchloremia as well as to give too much of hypotonic fluid in ringal lactate. So this is the choice of fluid for initial resuscitation. 5% dextrose is as good as normal saline initial fluid therapy or maintenance fluid therapy? Yes, no? Absolutely no. See, this is dangerously hypotonic fluid, and the moment you give, you see, if I give 1 liter of 5% dextrose in plasma, after 15-20 minutes, the remaining amount is just 85 ml and nothing else. So 5% dextrose is dangerously hypotonic. It does not even increases your blood pressure. If you see that okay, gradually blood pressure increases, in no time it goes down in 15 to 20 minutes. So 5% dextrose even for maintenance therapy is not a good fluid. 5% dextrose is as good as calorie requirement when patient is NBM. All of us we give as 5% NS RL. Very, very common practice, right? You see that 5% dextrose contains 5 gram per deciliter. Now 5 gram per 100 ml gives 25 grams in 500 ml. 1 pint gives 25 grams, and 25 grams 1 gram into 4. So 1 pint of 5% dextrose gives just 100 kilocalories. Our requirement is 1800 to 2000 kilocalories. So if you give 4 pints, you are giving just 400 kilocalories, which never suffices even to cover the basic metabolism. So even in perioperative period, except patient is diabetic, to prevent starvation ketosis, not to prevent hypoglycemia. If you see carefully, diabetic patients never will have hypoglycemia in perioperative period, except very bad sepsis, right? So if you give good amount of fluid, monitor sugar, you can get rid of 5% excess from the table. It can definitely cause hyperglycemia and its adverse consequences in perioperative period. So we have to be extremely careful in selection of fluid even in perioperative period, even if patient is diabetic. Not, absolutely not to be utilized as a source of calorie. It is extremely poor source of calorie. If patient develops hypotension and decreased urine output while fluid resuscitation is ongoing, which is dopamine, renal dose dopamine, dobutamine is the drug of choice. Which one is the drug of choice? Adrenaline versus noradrenaline, dopamine versus noradrenaline. I would say in any shock, noradrenaline is the first vasopressor of choice. No dopamine, no dobutamine. The moment if patient is having hypotension, you start dobutamine, you will have it. Patient will further vasodilate and further worsen even if cardiac. So that's my next question, that dobutamine is the drug of choice for cardiogenic shock. Big no. I would say big no. I am talking about cardiogenic shock. When the blood pressure is less than 90 systolic, you start dobutamine, you will have it. The blood pressure may come up, the perfusion will go down, right? So the best or first, I would say, the choice of vasopressor in any kind of shock, including cardiogenic, is noradrenaline, and noradrenaline. Once the blood pressure comes up, you can add dobutamine in patients with cardiogenic shock, or in spite of that, if perfusion is not increasing, just to dilate little bit that tissue level, you can add dobutamine, but with extremely careful, not with non-invasive blood pressure monitoring, always with invasive blood pressure monitoring in ICU. So this is what, first choice of drug is always noradrenaline. So we have to give some kind of fluids to see fluid responsiveness. Not all the time. Something called virtual fluid challenge in ICU, that is passive leg raising. आपने बताया पेलू vasovagal आवे तो पग ऊंचा करता था. Now it is scientifically converted into passive leg raising. You just raise the leg with 45 degree and see the change in cardiac output. Here is a catch. It's not blood pressure. It is cardiac output that we see in ICU. We monitor a lot of patients on cardiac output. So any patient, we don't give just fluid challenge, because that fluid is, we have, if suppose the fluid challenge is negative, जो गया वो तो गया, fluid 500 ml गया तो गया, 1 liter गया तो गया, that is additional burden, and at the end of that we conclude, oh, this patient is not fluid responsive, let's start vasopressor, right? But that 1 liter, that body has to adjust, or ultimately it's our responsibility to get rid of with the help of diuretic or maybe dialysis. So virtual fluid challenge is most important, that we increase, we raise the level of the legs to 45 degree, we see the change in cardiac output, and we literally see that, okay, these are the patients that literally helps us that this patient is probable fluid responsive or probable fluid non-responsive. In non-responsive, we start vasopressor immediately, we manage on vasopressor, we never go towards giving additional burden of fluid. So actually PLR, called passive leg raising, mimics fluid challenge, which is internal fluid. Patient માં છે તો બહારથી શું કરવા આપવાનું, right? It's like that. So this is what I have already said. We have to give some kind of fluid. No. And last but not the least, balance salt solution, which is the future. Balance salt solution, I'll simplify for you. Whatever our plasma electrolytes, tonicity, osmolality and ingredients are there, if the same recipe is there available in the fluid, it is called balanced salt solution. It is like હવે બધી હોટલો ખુલે ને કે ઘર કા ખાના, right? It is the same thing. એ ભાઈ તમને ઘર જેવું લાગે. I don't know how it works, right? આપણે બહાર જઈએ ઘરનું ખાવા. But here it is mandatory, right? So any solution which matches closely, as close as possible, to plasma electrolytes and ingredients, tonicity and osmolality, it is called balanced salt solution. There are a lot of fluids in the market right now available, but no one who is superior. People are studying now. Probably next guideline we may be using as a first line therapy, because it prevents hyperchloremia, it prevents additional of lactate, because most of them are either acetate based solution or bicarbonate based solution. So this is very, very important that this kind of fluids may be the future. Only caveat here is expense, but believe me, initial expense, ultimately if we can prevent metabolic acidosis further worsening, nothing like it. So to conclude, fluids we need to administer as a drug. It is a complex, not like, please don't prescribe as 2 pints, 2 pints, 2 pints. Have prescription to titrate that fluid particularly at that particular time, and the requirement always changes over a period of time. And there are certain category of patients like traumatic brain injury or liver failure, renal failure, already cardiac issues, they need to be sub titrated to lower amount of fluid rather than just giving bolus. So it is called SOSD concept, that first whenever patient comes with hypotension and shock, we have to give lot of fluids as a salvage therapy. Then you see the targets are achieved, then there will be optimization of fluid, like I have given 1 liter, now I will give 250 ml per hour and see, plus intermittent bolus if the hemodynamics warrant. Then patient goes into stabilization phase. Okay, I will give 60 or 80 or 100 ml per hour to be titrated, and then I would de-escalate or stop. Now this last point I would stress upon, that we need to have courage to stop fluid. Believe me, the IV pint is there and same day patient is being discharged. કે ચાલો હવે ઘેર જતા રહો, વાંધો નથી. Till last day it's our habit to give IV fluids. I would say it is add-on burden for our tissues to tackle this add-on amount of fluid. Thank you very much, and I'm happy I'm not saying this.
Dr. Ritesh bhai, thank you for differentiating the hypovolemia and the dehydration. I congratulate you to define IV fluids as a medicine. Thank you very much. One or two questions, please.
So at least I hope and wish that the practice